So I'm sorry, I need to change now into English. I'm sorry, I cannot continue with the Italian language, but I hope that's okay for you. So if you're telling at the end the question in Italian, I need to have some translation, but. So thanks for the kind introduction. Thanks to the previous speaker too, because, you know, we are doing now a clinical application. And I will not actually telling anything about artificial intelligence, but I try to conclude or to present actually first clinical applications. Thank you so much for inviting me. I have nothing to disclose. That's my agenda. I don't want to go too much in details because it's already late in the afternoon, but I will describe the main topics. We are talking about coronary artery diseases. With the age, we have atherosclerotic diseases coming in our results. For sure, everyone knows actually the side effects. Everyone is aware of people who had, for example, a stroke, a myocardial infarction, and I don't need to explain that this is actually a severe disease. We in the Air Force, where I'm coming from, we would like to prevent as much as possible future outcome or the horrible outcome. That means we have a person in a certain function who is within no time actually out of his function. He cannot fly anymore an airplane, he cannot drive a truck, he cannot press any button. That's not an option anymore. So that's why we are doing here a prevention as best as we can. You know, we have risk factors, smoking, diabetes, obesity, family history, and so on, even genetic testings. There are different things can be tested. And today, I want to show you the previous result, potentially for a new generation, new analysis. But first, we are going back, just that you know where are we coming from and where are we going. We have actually in Switzerland, I'm testing our people once a year, more or less, and we have our scores. Hypercholesterolemia, blood pressure, and so on. We are using so-called AGLA score, ProCam scores, and then you have a certain risk, individual risk for that person. If you have a higher level, you have a clinic, you have symptomatic, you're using additional testings like coronary CTs, MRI. For sure, you can use ultrasound, well cells, ultrasound, for sure genetic testing, but genetic testing, there we have a law problem. I cannot perform genetic testing on everyone, that's not permitted, so I'm restricted. And then I need to conclude, and we need to do a proposition and an evaluation. As said before, a helicopter, for example, you know, if a pilot is not working, the helicopter is not flying anymore. For sure, you have a UAV, you have new technologies, new options. But today, if you have a Rega helicopter or someone who's flying to Italy, I hope it works. But people are getting older. The age is the biggest risk factors we are taking with. as I heard from a previous speaker too, you know, we want to keep staying young. We don't want to get older. So, okay, there are two lines getting in another direction. And then for sure, we have population demands, you know, society is demanding things, but today too, we have additional risk factors. Sitting here behind the PlayStation, not running around anymore in the woods. You know, different things are coming up. On our own, we are testing more or less 6,000 people a year. We're taking blood samples, we are taking all the risk factors, as said before, blood pressure, and so on. In our population, Switzerland, or Swiss population, Italy is surely better. Spain too, I guess. I don't know. But in Switzerland, we have 50% of our people have elevated cholesterol levels. Huge number. We said we are doing with people who have elevated cholesterol levels, we are taking or applying the AGLA score. That's a blood pressure, family history of stroke, myocardial infarction before the age of 60, smoking, diabetes, and so on. And there is a risk result coming out. That means if someone has 10% result, that means the next 10 years, there is a 10% chance he's having a myocardial infarction or anything similar in the way. That's pretty high. That's why we said when someone is above 0.75, we are looking closer to that person doing, for example, coronary CTI, MRI, whatever, just to look how the coronary results are presenting. Some more background information. There are different publications, recommendations where I am involved too, just for risk mitigation, risk stratification, and so on. And we try to compromise and to reduce the risk for an individual person. When we are sending, for example, a soldier out of the country and he has an elevated risk, I cannot call the ambulance, he will not come back. And that's why we are reducing that risk. Yeah, some publication and we were sometimes a little bit ahead of the European Cardiology Society. That's sometimes an advantage, sometimes a disadvantage. That's our flow chart. I don't want to go here in too much in details, but you need to imagine when someone has an elevated risk, we are putting someone in the coronary CT, you know, we are doing a radiographic examination without just a medical indication. That's preventive measures. Risk calculation, I guess you know the risk matrix, how it works. You can have the reference over there. You have the increasance of the likelihood of no occurrence and the increase in severity of the outcome, and then you are middle in the red, and then you need to make a decision. As said before, we have in Switzerland just, you know, cholesterol and increased risk factors. And we try to do or to apply the best prevention we can do that the major topic, the major risk is not happening. For sure, we cannot prevent always everything, that's clear. But without all the population, without all, or within all the people we are examining, I want to grab the right people out. Purpose of the study. I will go further down in detail, but with new censoring, with the combining of the previous information with the artificial intelligence, what has been described in the previous talk, we believe we are on the way to develop a new screening technology, a new bedside screening technology. Here in detail, what are we doing? We are taking samples, ECG, the pretty normal ECG, nothing new. Infrared reflectometer and the Doppler on the legs. Putting those data together, it takes 15 minutes maximum installing, recording the information. For sure, you need to have a Wi-Fi connection, you need to put it on the cloud, so somewhere in the field there we have some problems, but you know, in our center it works, so everything is working fine. Putting all the things together. We have per selection, per testing more or less now, 6,000 new data coming together. As an individual, as a doctor, no chance to do the analysis myself. Just forget it. I will show you graphs because those are the interesting things. Artificial intelligence, well defined before. I think I don't need to go now more in details. Complexity, you know, the networking together, and at the end, coming back from the forest to the tree, there are different options. Deep learning, and so on, all the things just said before. Because with a new technology, the goal is, or the new testings, that the medic who's sitting, standing bedside is receiving something in the hand and saying, come on, Mr. Miller, you are at high risk. We need to do further examination. You cannot see it in detail, but I will explain it. You have a laser pointer somewhere? No. There is no laser pointer. Okay. You see, you know, actually no accident. Oh, yeah. That one here. Excellent. You have here, you know, data from the infrared, actually what you're receiving. Below, you cannot see it in detail, but here is actually the pulse curve. What you see here, you are comparing actually those two things, left and right, and you see here small other actually curves coming up. And you try to correlate those now with, hopefully with an increasing data bank. And I don't know so far yet if those small new curves, what I can detect is already a first sign of a, I would say, a major projection of a new or potentially a major event. For sure, there were just two cases. We have the whole history. We could look on a retrospective way. We are trying to look for a prospective way to increase the data bank that we, with the AI option and support, that we can evaluate a new outcome, a new risk stratification. In summary, so far, with our 19 patients we have examined, thanks to the engineer, with all the support, with all the technology, last second things, tremendous good, that we believe with the further analysis of all the data we have received, that we can set up an initial basic database where we can start moving in the further direction. That we are receiving, that we can provide a bedside new risk stratification for evaluating atherosclerotic diseases or potential atherosclerotic diseases, with the goal to prevent the major diseases, the major causes like myocardial infarction, stroke, and other atherosclerotic diseases. For sure, in future, perhaps mild dementia, whatever, you know, there are a lot of options. That's why we are defining a training phase. We try to predict the phase, and then for sure the looping phase, to actually bring things together and then define it and summarize it in future. I want to thanks to my small team on the back who were working and jumping, even Thomas. And for sure Periso, and we believe here we can develop actually a new step, and hopefully with a new step, a new generation, where we can actually change the previous pathway, the previous initial decision tree, in a way that we have here a new technology and providing a good service to the individual person who maybe or might be have a benefit of prevention of major diseases. Thank you for your attention. I give back the word to the moderators.